Well, hello, and welcome everybody to this second panel discussion organized by the Living Ethics International Network. My name is Karen Herrera, and now I heard Eric already introduce me. So I'm going to be the moderator in this panel. Could you change the slide, please, Benedict? So this panel is part of a series of events organized by Eric Rosine, who is the master behind all of this, by Cynthia, and by me. Can you change the slide, please? The series are supported by different partner institutions. And could you click this over, please? And again, this is our second panel entitled Living Ethics, Listening and Learning from Experiences. Could you please? Thank you so much. Okay, so I will give a little bit of background before introducing our speakers, and then we will start the panel. Could you click? Thank you, Isadora. So, living ethics has been proposed to be a stance. This means that it's not a concept, it is not a theory, it is not a principle, but instead is a position of or orientation to ethics, focusing on listening and learning from profound and diverse human experiences to achieve human development and flourishing. Please, I do encourage all of you to read this inaugural paper to learn more about living ethics. Could you please change the slide? Okay, today we will focus on experiences, and our speakers, we have the honor to have great speakers today. First of all is Abdou Senghor. He earned his PhD in sociology from the University of Toulouse-Jos in France. He's interested in analyzing the social construction of medical decisions, therapeutic choices, and trust in treatment decision-making. As a postdoctoral fellow at the University of Maryland School of Pharmacy, he is developing concepts and methods to address bioethical dilemmas in the context of community-engaged research to promote health equity. He also uses ethnographic methods to conduct reflective analysis based on his experience with chronic kidney disease. Unfortunately, due to an unexpected situation, Giulia won't be able to join us today, so I'm going to skip her bio. Then we have the honor to have Bénédicte D'Anjou. She is pursuing a PhD in information studies at McGill University. She holds a graduate certificate in information and knowledge management at McGill, and both MA and MBA in philosophy. Her work focuses on ethical issues related to the transmission and production of information and knowledge. Concurrently, Bénédicte also holds the position of research coordinator at the Pragmatic Health Ethics Research Unit, where she has coordinated a living lab in ethics and conducted associated pilot projects. And then we also have the honor to have Grégory Aiguier. He has a PhD in medical sciences after a course in educational sciences. His research is devoted to the implementation of ethics in healthcare organizations. The hypothesis that structures his work is based on the idea of ethics considered as a collective approach to learning, either actional, organizational, or social. In addition to his research and teaching activities, he supports health establishments and institutions in the deployment of ethics by questioning, in particular, the impact of ethics on the governance of structures. Deputy Director of the Center for Medical Ethics, and he's also a Deputy Director of the School of Society Sciences at the Catholic University of Lille. More specifically responsible for the sector management of health and social organizations. Okay, could you, can I have this next slide? Thank you. So I'm gonna give just a little notes and some instructions. Please use the question answer tool that you have to ask questions or make any comments. or you can raise your hand with a little icon. You can click the icon, and we will give you access to the microphone to ask your questions or formulate your comments. Please just try to make the questions brief and direct, and I can translate your questions formulated in Spanish to English, and Eric can translate from French to English. The next one, please. So now we're going to start the panel, okay? So the first question that we have for the panelists is, what are the benefits and challenges that you foresee in integrating different perspectives to achieve a living ethics? So I think we can start in the order that I presented you guys, if you're okay. So maybe we can hear first Abdou for his comments on this question.
Okay, thank you so much for leading this. So I think I'm gonna use my status as a patient, I'm a kidney transplant patient. So I'm gonna give an example from my previous experience. So when I went to France, I think it was in 2009, like I went to France to get a kidney transplantation. And when I went to France for a kidney transplant, my mother was worried, and I was worried too. So because a healer told her that there was a surgery I shouldn't have. So it was revealed that by the healer to her that that surgery could cause complications. So, and in Senegal, because I'm Senegalese, we trust these healers and their predictions because we have proof that these predictions come true. So even if the doctor in France revealed to me that according to studies, only 1% of kidney transplant patients die, I was hesitating to get a kidney transplantation in France. So when I connect that to living ethics, I should say that it is important, like in a country or in a study, including the social cultural factors to include these healers and these different perspectives, because it is a co-learning process. And I know that even if we know that numbers, evidence is important, they are not coming with the whole information. And the experience of patients is also important. And that's the reason why we should avoid falling into the trap of making evidence normative by placing it over experience. And I think it is a great thing to connect both experience and evidence to achieve that goal to make the life of patients better. So this is one of my thought about how to incorporate the things, the different perspective of stakeholders to make living ethics more flourishing and helping patients and health professionals to achieve the same goal. So it is the quality of life, the quality of care for patients. Thank you.
Maybe I can go ahead. So thank you for having me and for organizing this wonderful event. So there's a lot of benefits in integrating different perspectives. And I would say that for me, those are really similar to participatory action research, because I'm thinking of this question more in a epistemic ways. So for me, it's that it allows a better understandings of moral issue, because we know that singular perspectives can lead to a partial understanding of moral issue. And we have encountered this several times in our project with patients and healthcare providers when some aspects of the issue were more appreciated than others by some individuals of groups, because we're not faced the same way. We do not face these issues the same way. So we cannot see and appreciate everything. So if we would only consider the perspective of patients, we wouldn't see some limits or some other factors that can contribute to the issue. So for us, it was really important to integrate all those perspectives. But at the same time, one of the main challenges is that it's really difficult to do and it's more time consuming. So you have to identify like who we should consult to. So the perspective of who is important to understand the issue. So this is a big question, but also how and when could we meet with them? And at the end, even if you met with everyone, there's the complexity of being sure to consider equally every perspective. And this can be hard, but I think that even if it's maybe more complex to do to integrate many perspectives, it's really important and necessary if we want to have like a more appropriate understanding of the issue. So yeah.
Thank you, Bénédicte. Grégory, could you share with us your thoughts on regard this question?
Grégory is muted. Grégory, we cannot hear you.
Sorry.
No problem. Thank you.
Thank you, Grégory.
Before I begin, I would like to apologize for my very approximate English. I will probably have difficulty participating actively to the discussions. Bon. Alors, to begin, I would like to focus my reflection on the concept of experience. In healthcare institutions, the concept of experience is very present, but experience is often called when it comes to analyze practices or work on undesirable events. The work on experience is therefore often integrated into procedures, allowing a normative regulation of practices based on a predetermined set of practices and values. In healthcare institutions, for me, we live experiences, but we don't not learn enough from this experience. The work done on a lived experience, therefore, pursues a comprehensive aim. It aims to build a shared representation of actions. But the complexity of care situations, with the digital shift in health, with the strengthening of the value of autonomy, participation, inclusion, or with the crisis of meaning and vocation, makes you think about the experience differently. It's particularly important to place it in a more experimental framework, which encourages creativity. It's also about rethinking the values of care. The values of care are not spontaneously shared. Values are not self-evident. Values must be built within a broader community of care: professionals, patients, families, citizens. For me, this is one of the functions of ethical intervention in healthcare. This is developed with collaborative approaches, for example, co-design workshops. I'm currently participating in a project which aims to build a new palliative care offering. The construction of this new service includes families and caregivers. Collectively, drawing on their experience, they built the service project. The challenge is, of course, to take better care of patients, but also not to forget families. The challenge is also to center the discussion on essential subjects: the life, the experienced life in all dimensions, life sometimes forgotten given a technical, scientific, procedural approach to care. About benefits, I think globally, reconnect with the hedonistic perspective of ethics. The participation of patients and their families modifies the content of discussions. They tell what is important to them. This can create a stronger bond between caregivers and patients. Other benefit, try to accept limits of human action, learn to accept doubt. But on a cultural and professional level, it's very difficult. It's also a question of professional identity. In short, with the progress of medicine, try to humanize practices that have become highly techno-scientific. About challenges, I would say rethink care. Rethink care, that is, try to exit institutional and professional procedures that alter the meaning of the care actions. Try to not standardize practices. Try to build a professional and moral community by accepting diversity and singularity. In fact, moving from community of practices to a more inclusive community of care. For that, rethinking ILS training is essential. ILS training is based on a techno-scientific approach on performance. For me, it's an educational, social, and political questions. What is care? Care must become a social project, and we need a social debate. The integration of patients and their families is a lead in training in hospitals for discuss organization of care. In France, we are only starting. This requires getting out of the logic of power. This also requires an examination of the functioning of the healthcare institutions to exit of vertical logic.
Thank you, Gregory. So what we have been listening from you guys, it's this listening to the narrative from for example what Abdou said is like the narrative of someone who has knowledge as professional but also experience as the patient, and then Bénédicte is telling us to validate all these diverse perspectives as equals, but integrating this will demand more time and demand more effort to the professional. And then Gregory, you're telling us that we need to integrate experience in the healthcare system with all the stakeholders, that we need to integrate and listen the family and all the people that is taking care of these patients. And what I found very interesting, it's what all of you are saying is kind of the phenomenology of the patients when we listen to them, try to try to embrace it as part of her personal identity, just to know how to listen phenomenologies, not only data or that our patients are saying, but the full experience. Okay, I don't know if anyone has questions. I am a little bit limited here, Isadora, because I don't know how to see the questions. So would you help me with this? I don't see where is the chat for the questions, but could you help me here?
So maybe I can jump in, Karen, and read out the question. So what I'm gathering is the floor is open for a couple of questions. We can take some questions, Karen. If we can, we have one from Vincent Couture, who's an ethicist and philosopher based at Université Laval here in Quebec. He's asking what living ethics has to offer different than social sciences applied to healthcare and participatory research methodologies, which are already building on patient experiences, values, and perspectives.
Okay, who would like to jump on this question?
I can go.
Perfect, thank you.
Yeah, I think it is the first thing is to avoid harm people using experiences and using practices. For example, to me, medical practices are experiences, as well as patients experience and how they live with their disease. So there is an encounter of between health professional experiences and patients' experiences. So what living ethics it can bring is with the sharing or the encounter of experiences, we should have the possibility to share the experiences without harming other people. So by the fact that we learn each other from our experiences and we interact and we use these experiences in an ethical way that can contribute to make or to help people flourish without harming them. And and that's the reason why I developed the concept of experiential fallibilism, because when you use the medical practice that experience and you connect it to the patient experience without taking or considering the context, the situation of the patient, you can harm the patient. So living ethics can help us just getting into the context, into the situation, in a co-learning process that help the patients and all the stakeholders have the possibility to flourish and to learn each other and to use this experience for future practices or future encounters. So I think that is what living ethics can bring. It is how to reduce that harm that may possibly experience can do. So I think it is the goal, one of the goals of living ethics is by allowing different perspectives from different stakeholders, you can bring your own experience, but respectfully or being humble when you share that without a power imbalance. And that is why that experience can be ethical and can be something, can enrich living ethics. And I think it is what I consider that living ethics should be or should have to bring for both health professionals and patients.
Thank you, Abdou. Is anyone else from the panel would like to add anything else about what Abdou just said, or just to jump in the question also? Or
Yes, maybe what I would add, for me, it's all about flourishing. So I think that we can do participatory action research for a lot of goals, a lot of reasons. And for instance, we can develop technologies around like using those approach and methods. So the goal will not necessarily be to help or foster flourishing, but with the living ethics approach, we choose those methods because they help people flourish and to foster their autonomy. So for me, it's all about the goal. And also for me, the question is what it brings to ethics. And I think that for ethics, it brings new methods that allows ethics research to really meet those goals of flourishing and autonomy. So yeah.
thank you, Bénédicte. Okay, Gregory, do you have a? Would you like to jump in, or?
So perhaps it's an epistemological questions. Living ethics is nourished by lived experience. Social science mobilizes a theoretical framework, predeterminate the reflections. Often, for me, it's an epistemological question and perspective.
Thank you so much, Gregory. Eric, could you help me with the next question?
Sure. Actually, we have a colleague with her hand raised up who I'm going to allow to formulate your question. It's Carolyn Tate. Carolyn is from Manitoba, professor at the University of Calgary. She's the holder of a chair on Indigenous health equity. Carolyn, can you formulate your question for the panel?
Yeah, so can you hear me?
Perfectly. Thank you so
Okay.
much.
Perfect. And thank you, everybody. This is very interesting. And I work with Indigenous communities in Western Canada and actually around organ donation and transplantation. So, so how does living ethics apply to the context, like in the context of people here accessing healthcare and their healthcare journeys? Most of what they live through happens outside of hospital and clinical settings, but nevertheless impacts their health. And so there's a number of things when they, including cultural aspects, but also ideas of racism. And so racism with Indigenous people is historically situated as it is with other groups. And it builds upon a collective and individual experiences about um, what they should expect or what they might expect when they access healthcare. And this, where I live, is highly impactful in terms of the ways in which people feel about healthcare. So, for instance, an example would be when I asked Métis leaders about whether they would consider being organ donors, they came back and said, well, no, because if we indicate that we are organ donors, they may not give us care to save our lives if they want our organs, right? So this type of, so how does living ethics, how is it situated in relation to perceived systemic barriers, systemic racism, and how can we use it as a tool to possibly address some of the issues that people feel about our healthcare system? I don't know if that's an appropriate question, but but it's one that I struggle with. Thank you.
Absolutely. No, thank you so very much. Okay, who would like to jump in this question from Caroline? No volunteers?
I maybe I can suggest something. I think when we talk about organ donation, like in health systems, my suggestion would be to create a committee. Like when you create a committee where like people with or having that experience, like of organ donation or like receiving an organ, like we have that committee, and that committee could be connected to the policymakers or the board, like people who are like directing or the doctors undergoing kidney transplantation, for example. And I think there's experiences, you have that committee where people share their experiences and use those experiences to inform how organ donation or organ transplantation process should be promoted or should be maybe do it like in a better way. So I think like creating a committee where experiences can be shared with policymakers and people directing or undergoing kidney or organ donation or organ transplantation. It could be a great idea.
Thank you, Abdou. Is there anyone who would like to answer or have some additions to whatever to what just Abdou says?
Maybe what I could add is that for me, the goal of living ethics is bringing those concerns in the healthcare system. So by working with patients and healthcare providers. So for instance, with our project at the clinic here on patient psychological distress, we worked on an issue that can be considered as a private issue, psychological distress. It does not happen in the healthcare system, but it remains when a patient meets with his doctors. So for me, a benefit will be to bring this issue in the healthcare system, making healthcare providers more cognizant of that reality, of those concerns. So it's maybe not like it will not solve everything per se, but I think that helping, contributing to this perspective sharing could help or could be a good point to start.
Thank you, Bénédicte. Gregory, would you like to add something else, or should we go with the other question? Okay, I would just like to add for this question that I think living ethics, it's not only mindful of contextual and cultural differences, but it's proactive in trying to be competent on having, or at least having on the table, the competent people, which is like, the person from this specific context or this specific culture. So I think, yeah, it's kind of part of the plan to just narrow this gap on regards different ways, different perspectives or different contexts with different cultures, different expectations, and also to try to that living ethics can be useful in different systems of different countries or different contexts. So yeah, I just wanted to add that. Okay, do we have more questions, Eric?
We do. We have a comment and we have a question. So I'll just read the comment from Gita Devi Dorki, who reports learning recently about value-based learning. Interesting concept, I think, for us, value-based learning. He or she writes, for my region, Mauritius, a lot of emphasis is placed on collective decision obtained from family, especially in the end-of-life care to older people in the hospitals. So I think it was more of a comment. Then we have a question from our colleague Paul Ford, who's the director of the neuroethics program at the Cleveland Clinic, who Karen knows very well also. He's asking, how does living ethics account for those views of people who are unable, unwilling, or unavailable to participate in the conversation, but whose views may be pervasive, or if I may add, maybe fundamentally important in a certain issue? You have ideas to share on how a living ethics perspective could contribute to this issue. I think it relates a bit to Carolyn's question, I think, to some extent. People unheard in healthcare systems in particular.
Right. Who would like to answer this question?
I think that,
go on.
Thank you. I think that representation can be a solution, but at the same time, I think we should remain careful with representation because you cannot speak on behalf of someone else and wish to really represent their perspective. So to have like committees, as suggested by Abdou, is a great idea. For have those persons to have those perspectives represented. Maybe it will help. This could help represent the perspective of their peers, but at the same time, I would remain careful about like just considering that because we have people from a community, we have like automatically those perspectives represented as well. So I think for me, the goal would be to allow for as like many consultations and representations possible within the community to make sure that we just don't take for granted what others would say.
Thank you, Bénédicte. Who was going to who jumped also? Was it Gregory or Abdou?
Yeah, I agree with Bénédicte. So I think even in the Living Ethics Network, we have that problem. And I can give maybe an example, like a person who is deaf or blind may have the same health problems as people who who are normal, like yeah, if I can say that. So including them without necessarily referring to like evidence could be beneficial. And the thing is, how can we include these deaf people or blind people with same health problems? And what resources do they need to be included? And I think that is the first question. It's like living ethics is a stance, but to yeah, to me, living ethics can be beneficial and inclusive if we first identify the resources that people who are deaf, who are like autistic people, blind people, we have to identify their problem first to make living ethics uh, to make it like more inclusive and help patients to achieve their own goals. So depending on their values, depending on their life and how they live with their loved ones. So I think the first thing to address here is resources to identify their problems, the problems of these people, and then living ethics could help them with the different perspective and different resources to include them into a process that could help them achieve their own goals. I think even if you are working on Black health or if you are working on disability, you have to consider that because the health system have to be inclusive. And if living ethics wants to make the health system more effective and more like helping people to flourish, living ethics has to consider that and has to have these resources. Do we have that like in the living ethics networks? We are a group of researchers, but my proposition or suggestion would be maybe to create a stakeholders governance board, yeah, to help these people. Like, why not provide Braille for blind people, sign language for deaf people? And I think this is a best way to make living ethics more inclusive.
Thank you, Abdou. Gregory, would you like to step in or?
Just a comment about participation in the conversations. I think it's difficult because you can't force participation. Participation should be encouraged, but people do not always allow themselves. It's a difficulty, very difficult.
I agree. Paul, thank you for your question. But yeah, I agree. I think that the underrepresentation is and has been like a challenge for a long time. And yeah, I don't think we are too close to say that we represent everybody or everybody in the table representing this. This is a huge issue, especially if many people, especially from the global south, don't even know that that health is a human right, for example. So I have worked a lot on this issue, starting with the language that we need to speak like English so we can be at the table. So I think that we should start thinking on some people that can help us to be intermediaries and actually go to these underrepresented people with more tools instead of waiting for them to come, because I don't think this has been helpful. Okay, Eric, do we have more questions, or should we step to the next question, or what I mean, if we have more people that wants to
There are no sorry, there are no new questions, so feel free to move on to another topic for the panel.
Perfect. Okay. Isadora, oh, thank you. Okay, so our next question for the panel is how do you think different stakeholders, either professionals, patients, families, society, should be encouraged to listen and learn from the perspective of living ethics? Abdul, would you please start?
Yeah, I can start. So
Thank you.
I think it is. I disagree with listen and learn. I say that who listens? If you say listen and learn, how do we learn? And how blind people or autistic people or like deaf people learn? Or how deaf people listen? And I think, I don't know, it's the wording. Do we have to change? Should we change the wording or uh, how to make living ethics more inclusive? Uh, uh, if we maybe should we avoid this word or listen and learn, and how can we include these people, autistic people, blind people, or deaf people, and listen to what and who listen? I listen to that, but living ethics, for example, we have a project on living ethics. We wrote a paper on living ethics, but have we invited people, deaf people or like blind people, and give them these resources so that they can share their experiences and share how they think that should a living ethics should be. So that is my question. So yeah, I think it is the first thing to me to address. And if we address that question of listening and learning, so that we can move forward. But yeah, yeah, just make it possible, inclusive, so that all people, all kind of people, different perspectives should can be included. So, but because if you say that I want to listen, I want to learn, but I'm going to like the website, or you create a website on kidney disease, for example, and you want people share their experience about kidney disease, and you know that there are deaf people and blind people who suffer from like kidney disease, and if you don't not include them, yeah, I think you can do living ethics, but I think it will be a taconite stick living ethics. It is my perspective as a patient. I think we should maybe address this question when we want to listen and we want to learn each other and together,
Thank you,
from
Abdul.
each other and together.
Yeah, I think we also need to put the word receptiveness on the table, right? We need to be receptive. We listen to what we are receptive to. Benedict, could you please share with us your thoughts?
Yeah, so for me, it's all about perspective sharing. And I think that unfortunately we'll never have enough opportunities to share our perspectives with each others. But the good news is I think that there's a lot of ways that we can encourage or do perspective sharing. We can think, for instance, of academic channels such as papers or conference or lecture courses or panels, but there's also maybe more informal ways such as hallway discussions that are really useful, as well as podcasts. If we think also about networks, social networks, the discussion groups on social networks. So I think it's important to recognize those channels and to value them as great places for perspective sharing. And I think that for those sharings to be really fruitful, epistemic humility is really the key. So we need to remain open to the possibility, and in fact, not the possibility, but the fact that we don't know everything, and that we can be surprised by how much others have to teach us. Um, so yeah, so for me, it's if we want to listen and learn, we need first to be able to share those perspectives and to remain, as you said, Karen, really receptive to it.
Thank you, Benedict. And I also maybe we should add at the table the word humbleness, which is it's not it is not too common. Gregory, would you please share with us your thoughts too?
From my point of view, it's by the experience of participation that we can encourage the different stakeholders to listen and learn. But this obviously requires clearly defining the rules of participation. If participation is limited to consultations, this does little to encourage listening and learning. In training, when patients and students work together on subjects or projects, learning is more meaningful. And another example on a societal level is interesting with the citizen conventions. In France, the climate convention was poorly received because it remained exclusively consultative. The convention on the end of life was conducted in a more participatory framework. Even if Prime Minister Elizabeth Borne had announced from the start that the government would choose among the different proposals. In my research, we experiment the conditions of participatory governance in institutional projects. Stakeholders do not participate in a project that has already been built in a social inquiry logic. They participate in defining the problem, constructing working methods, experiments, and evaluating the project. But this remains difficult to carry out within institutions that operate vertically.
Okay, Gregory, thank you. So we should be start consider the possibility of rethinking what participation means, right? Or what participation you want. Okay, thank you. Do we have questions, Eric?
Not yet.
Okay, no
Okay,
questions
so
yet.
we can encourage everyone to write questions up. If not, you can freely exchange on this topic and react to each other.
Yeah. Well, yeah, because I think it will be interesting to know if you guys panelists have another after listening to all your colleagues, if you have like an additional thoughts, or because we are we listen right in this question about listening, what listening means, what learning means, what participation means. So do you think that we should I don't know, that we should go back and review concepts? Do you think that's what we should be doing? Whoever wants to answer my question, or nobody, it's okay.
I maybe have something maybe it depends on the projects on living ethics. Maybe if you conduct a project on blind people, you will certainly you will involve blind people, and you will give them resources to participate in your research, in your project. That is the first thing. So, but in a broader way, like if it is not a project, or if we are like the Living Ethics Network, for example, we are members. We have members who are like both patients and researchers, but we do not have maybe members with just a status of patient. So that I think it should be a great idea to have that, and to have resources, and to maybe let them know, or just have their perspective about what we have to, what we can do to include like these specific populations or specific patients with specific needs, like autistic people, blind people, deaf people, so that we can include them, and then we will not just refer to evidence, but also but experience as well. I think that that can be a good thing to do, under the living ethics network. So we have that members of the living ethics networks, but we do not have like a board of patient and advocacy board who can help us with their own experiences, and who can help us maybe change, maybe depending on the situation or the context, the wording of how we should listen or we should like learn. So here is my thing.
Thank you, Abdou. Thank you. Either Bénédicte or Gregory would like to add some comments. Okay. I don't know if we have time for the third question. Maybe we could do it, and if you panelists could be just brief, just to have a little a couple of minutes at the end for questions. Isadora, would you help me with the slides? So we're gonna try to do this one super fast. The last question is if you think that listening and therefore being more intimate with patients' experiences will have a personal impact on healthcare professional ethicists or others, such as emotional impact, philosophical impact. If you could please just be super brief, but I wanted to address this question. So Abdul, it's your turn again. Thank you.
Yeah, I think my what I want to do is say is just that we have to connect or just make that encounter between evidence and experience, that encounter works with both health professionals and patients. And my last word is proof with numbers doesn't often reveal compassion, but sharing experience does. But the other thing is we must also ensure that these experiences do not harm others psychologically. So evidence has its own benefits and challenges, and so does experiences. So
thank you.
So do experience. So yeah, thank you.
Thank you, Abdul. Bénédicte, would you have like a short intervention, please?
Yes, sure. So I think it's absolutely necessary to better understand other perspectives and experience to better grasp their needs. But at the same time, I think it's really important to recognize that sharing might be the impact that it might have might not be positive, that it might be uncomfortable, because healthcare providers they have some constraints and limitations, so they may not be able to act in responses to the issue they're exposed to. So I think it's important to recognize that. And also I think it should be the other way as well. So the question is more about if the patient's experience should be known by healthcare providers, but I think that the perspective and experience of healthcare providers and ethicists should also be known by patients. I think it will help them better understand their own experiences with the healthcare system, to see those limitations and norms and constraints that explain in part the experience that they have. So yeah.
Thank you, Bénédicte. Gregory, could you share with us your point of view, like short?
Yes, on my point of view, stakeholders are transformed by discussions. For example, in dependent seniors institutions, we experiment ethical discussions with residents. They upset us and shift the discussions to aspects no longer only technical or clinical. We are talking about life, their lives in the institution, their lives before entering the institution. They tell us what they really care about, what is important to them. We find in some way the foundation of Dewey's theory of valuations, defining what is important to us. So different dimensions are therefore evoked, emotions, spirituality, etc.
Thank you so much, Gregory. I don't think, well, no, it's not, I think we don't have time for questions for this last intervention. Isadora, could you help me with the slides? We want to thank you, or to our panelists today, and to all of you for being here with us, for listening and participating to the ongoing development of living ethics. So we have our third panel on May 1st. We really would like to see you all there and invite your colleagues. The next panel is going to be about imagining living ethics in different contexts, which I think this was some of the concerns or questions that we had today. Our panelists for that session will be Anne-Sophie Guernon, Judy Illes, Félix Pageau, and Katja Kühlmeyer, and Cynthia will be moderating this panel. And also, well, we have really exciting news. Could you have the next slide, please, Isadora? Our official Living Ethics International website is already published. I believe the link is on the chat. You can also sign up for our newsletter, so you can find the website and other news, publications, events, and all the work that we're trying to achieve and do with all of you. And I don't know, Eric, if you have like some last remarks so we can say goodbye.
Thank you. Thank you so much. Thank you, Karen. It was a wonderful panel. And I think what to keep in mind is living ethics is something to develop. So I think all the relevant questions that challenge how we can make ethics live, how we can make ethics connect to experience, are all, in a way, challenges, but also opportunities to actually move ahead and expand how we do things and do better. So I think we had other questions in the chat. I didn't have a chance to read them out loud to you, but we were asking questions, beyond listening and learning, should acting be part of living ethics? We had this was another question from Vincent Couture. We had Michel Jean asking questions about how to build from literature and experiences in citizen participation, for example. And we had another question from Félix Pageau, who's an upcoming panelist, actually, asking how powerful people who do not wish to participate, how do we deal with them? Because they have an influence, but sometimes they don't want to partake to our projects or initiatives and so on. So these are all fantastic questions. I think they're inviting us to move ahead. And I think, again, I want to thank everyone, and including you, Karen, for organizing this panel and sharing it. And our thoughts to Giulia also. And hopefully she's all well after this morning's events.
Thank you for your closing remarks, Eric, and thank you all. We really wish we really hope to see you next panel. Thank you so very much for everything, and don't forget to visit the website. Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you. Thanks to both of you. We're still there. Bye, Karen. Oops, Karen, I can't hear you. Oops.
Oh, yes, I'm sorry. I was saying thank you so much for helping me with the questions and the slides. And I'm so sorry that I had to do this by the phone. I'm sorry.
No, it worked out well. It's fantastic. And your sharing of all the materials I had allowed me to help out. So thanks for doing that.
No, thank you. Okay, take care, guys. And